Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen, you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm, and I'll give you my treatment. Enjoy the card, and good luck.
3, 2, 1.
Pediatric rhythm interpretation can be challenging, but just remember that rhythm interpretation for pediatric patients follows many of the same rules that we would use for interpreting rhythms for adult patients. Let's go ahead and take a look at it in a little bit closer detail. Now, the first thing I like to do with any rhythm is count the R waves. I'm counting 35 R waves here, which makes the rate approximately 350 BPM. This is fast, even for pediatric patients. Next thing I'll do is I'll examine the R to R interval. The R to R interval here looks fairly consistent. I'm also not seeing any real good identifiable P waves. I'll then measure the QRS interval, and I'm finding that it's wide. Because of this wide QRS interval, no discernible P wave, and a regular R to R interval, I know that this rhythm is being initiated below the atria and the AV node. And because this rate is well over 100, the only possibility for this rhythm's identification is ventricular tachycardia, or VTach. Now, let's go ahead and take a look at the scenario. You were dispatched to a private residence for a 4-year-old female having seizures. Upon arrival, you find your patient lying on the patio, unresponsive, apneic, and pulseless. Family members report that the patient was playing with her older siblings when she appeared to have a seizure and then fell to the ground. The family denies any known medical history, but states that the patient is adopted, so they are unsure if she has any relevant family history. A rapid physical assessment reveals no pertinent findings, and vital signs are unobtainable. You determine the patient's weight to be 15 kilos and then begin performing chest compressions. Your partner obtains a blood glucose reading of 106 and attaches the monitor. You see the rhythm above. Now, the seizure activity that you were called out on initially was likely the result of hypoxia due to this non-perfusing rhythm causing a reduction in blood flow to the brain. It's very common for rescuers and lay people to witness seizure activity immediately prior to a cardiac arrest event, and this is simply because the non-perfusing rhythms do not allow oxygenation and circulation to the brain. It should also be noted that pulseless VTach is incredibly rare in this age group and is very likely the result of an underlying cardiomyopathy or channelopathy that may have been present from birth. To be successful in static cardiology, not only do you have to identify the rhythm correctly, but you must treat it appropriately. Part of appropriate management is the determination of whether or not this patient is stable or unstable. For my unstable criteria, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Based on this patient's current presentation, my final diagnosis for static cardiology is an unstable pulseless VTAC. Let's go ahead now and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra. Scene safe, BSI, IV O2 monitor. Remember, this is a CPR event, and because this is a pediatric patient, we'll be doing CPR in cycles of 15 to 2. So 15 compressions for 2 breaths, until an advanced airway is established. And because hypoxia is one of the leading causes of cardiac arrest in children, we'll make sure that we're providing ventilations with the BVM attached to 100% oxygen. Now keep in mind, pulseless VTAC is a shockable rhythm, just like ventricular fibrillation. So for this patient, the most definitive treatment besides CPR is going to be attaching the pads and defibrillating this patient every 2 minutes. As this patient is pediatric, we will be using weight-based dosing. So the first shock will be delivered at 2 joules per kilogram. And remember, based on this patient's weight of 15 kilos, that first shock will be 30 joules. My second shock, which will occur in 2 minutes, will be at 4 joules per kilogram. So based on this patient's weight of 15 kilos, this will now be 60 joules. Subsequent defibrillations beyond that second shock, we can increase our joulage all the way up into a maximum dose of 10 joules per kilogram, with 150 joules being our maximum energy for this patient. Medication-wise, I'll be administering epinephrine to this patient, the 1 to 10,000 concentration, and this will be dosed at 0.01 milligrams per kilogram. So based on this patient's weight of 15 kilos, they'll be receiving 0.15 milligrams IV every 3 to 5 minutes. On a typical amp of epinephrine, this will work out to 1.5 milliliters. My second-line medication, which can be given for pulseless VTAC, will be amiodarone. This will be dosed at 5 milligrams per kilogram. Based on her weight, this will be 75 milligrams, given IV push every 5 minutes for a maximum of 3 doses. And usually, this is given in between doses of epinephrine. As an alternative to amiodarone, or after I've maxed out the amiodarone, I could consider giving lidocaine. Lidocaine will be dosed at 1 milligram per kilogram. Based on this patient's weight, this will be 15 milligrams given IV push. I'll then consider placement of advanced airway and consider my reversible causes of cardiac arrest, otherwise known as the H's and T's. And finally, rapid transport. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, make sure you like and subscribe and check out my other playlists like Hands-On Skills or Static Pharmacology. And also make sure you check out my store on Teespring for some EMTV merch. Every sale from the store goes to support my channel. Thank you so much again for watching. Until I see you next time, stay safe, keep washing your hands, have a good rest of your night.